Assalamualaikum and hello everyone. My name is Fatin Shurti binti Hamid and my student number is 2023817298. Today, for subject radiographic image evaluation, I will evaluate epiradius ulnar radiograph. First, let's start with the anatomy of radius ulnar. Based on what I have put here, approximately we have olecranon process, coronary process, coronary tubercle, proximal radio-ulnar joint, radial notch on ulna, head and neck of radius, radial tuberosity, body or shaft of both radius and ulnar notch on radius, head of ulna styloid process, distal radio-ulnar joint, and radius styloid process. This is the radiograph that I choose for this assignment. Usually in hospital, we will divide the image receptor into two to put two projections so that we can easily compare between epi projection and lateral projection to make sure to get a better view of the anatomy of radius ulnar. But today our main focus is epi radius ulnar. How I want to know this is radius ulnar? This is radius ulnar epi projection because we can see there is no superimpose of radius ulnar distally, and there are ribs also included at the superior border. But theoretically, epi radius ulnar projection should have the epicondyles of the humerus must be seen bilaterally and same in the size. We also must there is no superimposition of radius ulnar distally, and last but not least, not only the wrist must include at the superior border, but the elbow joint also must include at the inferior border. You can see here the difference between epi projection and lateral projection, whereby at the epi projection, the radius and ulna are seen bilaterally. Meanwhile, for the lateral projection, they are seen superimposed with each other. But today, we will evaluate the radiograph using Passman method. First and foremost, we will start with the positioning. Positioning have 5 criteria. The first one are the radial styloid is demonstrated in profile laterally. As we can see in the radiograph that I circled there, the radiograph, radial styloid process is in profile laterally. The second criteria is the radial tuberosity is demonstrated in profile medially. As we can see in the radiograph, the radial tuberosity is in profile as I circled there and demonstrated towards the middle. Next, we can see the radius and ulna seen bilaterally compared with the lateral projection where the radius and ulna superimpose with each other. The next one is minimal superimposition of metacarpal bases, also radius ulna. In this radiograph, there is no minimal superimposition of metacarpal bases, but at the radial tuberosity, we can see that the radial tuberosity are superimposed with the ulna. For the last criteria, is the long axis of radius ulna must align with long axis of image receptor. We can see at this radiograph that we use, the long axis of radius ulna are being parallel to the long axis of image receptor. There are a few conditions where there will be external or internal rotation of radius ulna. For distal radius ulna, we must pay attention at the carpal bones and metacarpal bases. If the carpal bones and metacarpal bases located on the medial aspect of the wrist are superimposed, it is indicate that the forearm are rotate external. Meanwhile, for internal rotation, carpal bones and metacarpal bases located on the lateral aspect of the wrist are superimposed. Next, for proximal radius ulna, we must look out for the radial head and radial tuberosity. If radial head and radial tuberosity superimposed with ulna less than 0.6 cm, it is external radiation. And for internal rotation will happen when radial head and radial tuberosity superimposed with ulna more than 0.6 cm. Hence, we can say that in our radiograph, there are external rotation at the proximal of radius ulna. The improvement that we can do is to make sure that our radius ulna or our forearm are introlateral while we are doing the procedure. To enhance our understanding regarding this external or internal rotation, we can refer to this radiograph. We can see both rotation, such as at the distal radius ulna, it is external rotation as the carpal bones and metacarpal bases are located on the medial aspect of the wrist are superimposed. Meanwhile, at the proximal radius ulna, we can see the internal rotation as radial head and radial tuberosity are superimposed with ulna more than 0.6 cm. Just now we just explained about positioning. Now we will move on to the alignment. For alignment, we have 5 components that we need to look out, which is the first one is X-ray tube with image receptor, X-ray tube, second X-ray tube with patient, third image receptor with patient, 4 centering point of this radiograph, and lastly standard centering point for this projection. The alignment for this radiograph, for the first one, are the X-ray tube with image receptor. X-ray tube, which represent 4 borders of collimation, and image receptor, the edge of the film, cannot be determined as there is no 4 borders of collimation present in this radiograph. Second, X-ray tube with patient, which is 4 borders of collimation with central structure, also cannot be determined as there is no 4 borders of collimation. Thirdly, image receptor, which is edge of films and patient center structure, are incorrect because the distance between edge of film and central structure are not equal. Next, for the centering point, the centering point for this radiograph cannot be determined because there is no 4 borders of collimation. Lastly, the standard centering point for this projection is it should be at the mid shaft of the radius ulna. For a comparison, let's compare the radiograph on the left side and the right side. The alignment for this radiograph are incorrect as it does not include the olecranon process, olecranon fossa, and distal humerus, where we can assume that when performing this projection, the centering rays are not centered at the mid-shaft of the radius ulna. We had covered for positioning, alignment, so now we have come to the collimation. For collimation, it must include all of these, which is for superiorly, it must include wrist, metacarpal bases, and distal radial ulnar joints. Inferiorly, it must include olecranon fossa, olecranon process, and distal humerus. Lastly, for laterally, we must include radius, ulna, and forearm tissue. In this radiograph, there is no evidence of the radiation protection apparatus can be seen. Next, for the exposure factor, there's a certain part that we will look into. For example, for now the radius ulna, for contrast, the thin structure that we will look at is a bony cortical outline of ulnar styloid, and the thick structure for contrast is the bony cortical outline of olecranon process. Meanwhile, for density, the thin structure is bony tubercular pattern of ulnar styloid, and the thick structure is the bony tubercular pattern of olecranon process. The exposure factor for our radiograph cannot be fully determined as the olecranon process are cut off from this radiograph. But we can still evaluate with assuming the bony cortical outline and bony tubercular pattern of olecranon process by looking at the image for lateral projection of the same forearm. For the contrast, we can see the bony cortical outline of ulnar styloid and bony cortical outline of olecranon process. Meanwhile, for the density, we also can see the bony tubercular pattern of ulnar styloid and bony tubercular pattern of olecranon process. So, we can assume that both KVP and MAS were given adequately and does not have to change anything. Let's recap. We have covered for position, alignment, collimation, also exposure factor. Now we will move on to the marker. There is evidence of a digital marker shown in the radiograph, correctly placed on the right side of the body and placed appropriately, not superimposing any region of interest. Now we move to aesthetic. The film size that we should use is 35 cm times 43 cm, which is sufficient to demonstrate all structure of this interest, and it is sufficient to do comparison between epiprojection and lateral projection. Besides, other than 35-43 cm, we also can use a cassette with 30 cm times 35 cm, or we also can use 30 cm times 40 cm based on what we have on our lab. In this radiograph, there is no evidence of artifacts seen on the radiograph. We have come to the end of the passment method, which is name. In this radiograph, there is no patient name and ID number, date of examination and place of examination, Meanwhile, they should be clearly visualized on the radiograph at the appropriate area and not superimposed with structure of interest. In conclusion, should we accept or reject this radiograph? In my opinion, this radiograph should be rejected because it has incorrect positioning, incorrect alignment, presence of digital marker instead of anatomical marker, and there are no patient identification can be seen on the radiograph.